Welcome to the Funnel Effect. We're opening the vault today for a deep dive into, well, one of the most powerful and frankly high-stakes classes of medicine in emergency care, fibrinolytic therapy. You probably know them better as clot-busting drugs. And today we're really zeroing in on their approved indications. When exactly are they used? Now, our entire analysis, everything we're discussing, is based on a state-of-the-art review published in JCC, the Journal of the American College of Cardiology. That's a top-tier source, carries serious weight. And we really owe the depth of this knowledge to the authors. Sina Rashidi, Hannah Leva, Nada Hamedi, Mariana B. Pfifferman, Luis Ortega Paz, Param Siddiqui-Poor, Azita H. Talasaz, and Benud Bikdeli. Quite a team. So our mission today, for you listening, is pretty clear. We want you to quickly grasp what these life-saving drugs actually are, how they do their job, and, maybe most crucially, why their use is governed by some of the strictest, most condition-specific guidelines in modern medicine. Let's jump right in. Okay, so let's unpack this. Before we get into the really heavy stuff, what exactly is fibrinolytic therapy? Like, on a molecular level, what are we actually trying to break down here?
Right. So we're targeting the body's own repair mechanism, which sometimes, well, it goes wrong and creates a deadly roadblock. Essentially, fibrinolytic therapy is designed to manage these thromboembolic diseases. It does this by promoting something called plasmin-mediated fibrin degradation.
Fibrin.
Yeah.
That's the key component.
Exactly. Fibrin is the protein mesh, sort of the glue, that holds a blood clot together. It makes it stable. So by breaking down that fibrin mesh, these drugs achieve what we call vessel recanalization. Basically, they dissolve the clot, reopen the blocked artery or vein, and restore that critical blood flow. It's always a race against time, whether that clot is blocking blood flow to the heart, the brain, or maybe a limb.
Okay, and this is where, for me, it gets really interesting. The history. We tend to think of these as super modern, cutting-edge ER drugs. But the journey to get here, it's been nearly a century, hasn't it?
Oh, absolutely. The very first agent, streptokinase, wasn't a modern lab creation initially. It was actually discovered way back in 1933. It was a huge milestone, yes, but it definitely came with challenges, things like allergic reactions, and it affected the whole body, leading to side effects.
So what was the really big leap forward, the one that truly changed emergency medicine?
That came quite a bit later with the development of tissue plasminogen activator, or TPA. We mostly know it by the drug name Alteplase. Being able to create TPA using recombinant DNA technology, that was the massive breakthrough.
Why was that so significant?
Because it allowed us to harness a naturally occurring human enzyme. This made the therapy potentially more targeted, possibly less likely to cause those immune reactions compared to earlier agents like streptokinase.
Got it. But then the research didn't just stop there. We started hearing about drugs like tenecteplase, retplase, sort of next generation. If TPA was already so revolutionary, why the push to engineer these newer mutants, as some call them?
That's a great question. It wasn't necessarily about making them more effective at busting clots per se. It was more about practicality, about optimizing how we administer them. We call this pharmacodynamics.
Pharmacodynamics.
Yeah.
How the drug works in the body.
Exactly. How long it lasts, how it's cleared. See, TPA or Alteplase, it requires a pretty complex multi-stage infusion. It takes time, needs careful monitoring. Mutants like tenecteplase and rectoplase were specifically engineered to prolong their plasma half-life.
Meaning they stick around in the bloodstream longer.
Precisely. And think about what that means clinically. A longer half-life allows for simpler administration. For tenecteplase, this often translates to just a single rapid bolus dose.
Just one shot.
One quick injection. And in a life-or-death emergency setting, when every single second counts. That's an invaluable advantage. It just streamlines the whole care process dramatically.
That makes perfect sense. Simpler dosing means faster treatment. Okay, here's the critical pivot point, and the sources, especially the JCC review, really hammer this home. These drugs can be miracle workers 1 minute, but they carry immense risk. What's the fundamental high-stakes trade-off?
You've absolutely hit on the core conflict of this entire field of medicine. While these drugs are incredibly effective at, achieving that vessel recanalization we talked about, that power comes at a terrible potential price, an inherently increased risk of hemorrhagic events.
Bleeding. And what's the absolute worst-case scenario, the one that keeps doctors vigilant?
Intracranial bleeding, a hemorrhage inside the brain. It's devastating.
Because the same mechanism dissolving the bad clot
can unfortunately interfere with clotting elsewhere systemically. It can cause severe, even fatal bleeding. And because of this catastrophic danger, their usage isn't just, suggested, it's mandated by extremely restrictive and precise clinical guidelines. The risk is just so high that the drug's benefit in that specific situation must vastly outweigh that immediate possibility of causing a fatal bleed.
That context is absolutely vital. The sheer danger explains why we can't just give this to everyone with a suspected clot. Okay, so let's dive into those specific guidelines now, condition by condition. We're talking the major life-threatening situations, right?
Exactly. We really need to look at three critical areas first: severe heart attack, stroke, and major lung clots. So starting with STEMI, that's the ST elevation myocardial infarction, the most severe type of heart attack where a coronary artery is completely blocked. Now, fibrinolytic therapy is a fantastic option here, but the guidelines place it in a very specific box these days.
Which is?
It's currently restricted primarily to patients who absolutely cannot get to a hospital capable of primary percutaneous coronary intervention, or PCI.
That's the angioplasty and stent procedure.
Right. If they can't get that PCI within 120 minutes of first presentation, first medical contact usually.
So if you're perhaps in a rural area far from a specialized cath lab, fibrinolysis becomes the only viable path to save heart muscle in that critical early window.
Precisely. And this is where the complexity of the dosing really starts to reflect the seriousness of the risk.
Can you give us a snapshot? How precise are these STEMI regimens?
Oh, they're meticulous. Because the goal is rapid action without overwhelming the body's clotting system entirely. For 5E alteplase, for example, the administration is typically staggered. An initial bolus, like a quick push, followed by more drug infused over the next 30 or 60 minutes, and then even more over the following hour.
Okay, quite involved.
Contrast that with IV retroplase. That's often two simple 10-unit boluses given exactly 30 minutes apart. Simpler, maybe faster overall.
And tenecteplase, you mentioned it has that advantage of the single bolus. Does its regimen still have safety modifications built in?
Absolutely. Tenecteplase is typically dosed based on the patient's weight, and it's administered super fast, over just 5 seconds. But here's that risk mitigation you mentioned in action. Patients over 75 years old, they frequently receive a specific half-dose regimen.
Half dose. Why?
Because advanced age is a known major risk factor for bleeding complications. The guidelines literally dial back the power of the drug for older individuals to try and balance efficacy with safety.
Okay, that makes sense. Let's shift gears now to acute ischemic stroke. This is where a clot blocks blood flow to the brain. We always hear about the incredibly strict time window here. Again, speaks to that life and death trade-off, doesn't it?
That time window is everything in stroke. Fibrinolysis is a cornerstone treatment, yes, but it must be administered within 4.5 hours of when the symptoms first started.
4.5 hours, that's it.
That 4.5-hour cutoff is basically non-negotiable based on all the evidence balancing the potential benefit against that risk of brain hemorrhage.
So what's the standard regimen for stroke? How is the precision managed there?
Well, the gold standard for 5E alteplase in stroke is 0.9 milligrams per kilogram of body weight. Notice the weight-based dosing again, very precise. And there's also a hard cap. A strict maximum total dose of 90 milligrams, no matter how much the patient weighs.
Okay.
And the delivery method is also key. Only 10% of that total dose is given right away, as an initial bolus over just 1 minute. The remaining 90%, that's infused slowly over the next hour.
Wow, that level of detail is staggering. It really sounds like giving even a little bit too much or too fast could significantly ramp up that intracranial hemorrhage risk.
It absolutely does. And interestingly, tenecteplase is increasingly being explored and even used as an alternative here too.
Because of the easier administration.
Exactly. Leveraging that potential for simpler, faster bolus dosing within that very narrow therapeutic window for stroke.
Okay. Our final major indication from that top three, pulmonary embolism, or PE. That's a clot lodged in the arteries of the lungs. When does this situation become so dangerous that these aggressive clot busters are needed?
Right, so PE is categorized by risk level. Fibrinolytic therapy is reserved almost exclusively for what we call high-risk PE. This is PE that's associated with hemodynamic compromise.
Meaning the patient's vitals are crashing.
Precisely. Their blood pressure is dropping dangerously low. They might be showing signs of shock, or they could even be in cardiac arrest because of the clot-blocking blood flow through the lungs. It's only in those immediate life-threatening situations that the danger from the clot itself outweighs the significant risk of causing major bleeding with the drug.
And what do those PE regimens typically look like? Still systemic?
Yes, they are still systemic and serious business. Regimens usually involve IV alteplase, often a dose like 100 milligrams administered over 2 hours, Or there are alternatives like IV urokinase or even IV streptokinase in some guidelines or regions, but the underlying principle, it's always the same. If the patient is crashing due to the PE, you have to try and dissolve that clot immediately, despite the high inherent bleeding risk.
That clarity is just. It's absolutely essential for understanding why these decisions are so complex in emergency medicine. It really highlights that the precise timing, the exact diagnosis, the patient's overall stability, it's literally everything when deciding whether to deploy these powerful, potentially dangerous tools. Okay, so we've covered the big three: heart attack, stroke, massive PE. Now, let's broaden the view a bit. Our sources, the JACC review included, also discuss other applications, situations where fibrinolytic therapy might save limbs or maintain other essential bodily functions, and this seems to be where we start seeing more specialization in how the drug is actually delivered. Where else do the guidelines approve its use?
Yeah, there are several other clinically important indications, and as you pointed out, they often involve a shift away from that systemic, whole-body IV delivery towards more targeted, local delivery methods. Take DVT, deep vein thrombosis, for instance. We're not talking about every DVT, but rather severe and proximal ones, clots high up in the large veins of the leg or pelvis, the ones posing a greater risk of long-term complications or breaking off.
And how is it used there?
Here, the drug, often alteplase or urokinase, is frequently delivered via a catheter-directed route.
Meaning a catheter snakes right up to the clot.
Exactly. And the drug is infused slowly, right at the site, sometimes over 12 to 24 hours, or maybe even up to 1 to 3 days in some protocols.
That long infusion time, delivered locally via catheter, that seems deliberately designed to minimize the systemic bleeding risk while maximizing the local clot breakdown effect, right?
That's precisely the goal. And the same principle applies to acute limb ischemia. This is when a clot suddenly blocks blood flow to an arm, or, more commonly, a leg, threatening the viability of the limb itself. To restore circulation quickly and save the limb, catheter-directed alteplase or urokinase is often the approved thrombolytic route. Again, you're trading maybe a bit of time for potentially greater safety by reducing the overall dose hitting the entire system.
What about clots forming on artificial parts inside the body, like heart valves?
Right, that's mechanical prosthetic valve thrombosis, or PVT. A clot forming on an artificial heart valve is a serious problem. Fibrinolysis can be used particularly for obstructive clots on left-sided mechanical valves, mitral or aortic. The regimens here typically go back to IV alteplase or sometimes streptokinase.
So systemic again for that one. Why?
Because the risk of the clot causing a stroke by breaking off or leading to acute heart failure is just so incredibly high in that specific scenario. The potential benefit of rapidly dissolving the clot justifies taking this systemic bleeding risk once more.
Okay, got it. And finally, there's less dramatic but still medically essential use, just clearing out blocked access lines.
Yep, exactly. For central venous access device, CVAD occlusion, this is simply when a patient's central line, maybe a portacath or a PICC line, gets blocked by a small clot inside the tubing. To salvage that important line without replacing it, they typically use intraluminal alteplase.
Intraluminal?
Yeah.
Meaning just inside the tube.
Right. The drug is instilled directly into the catheter tube itself, left to dwell for a bit, and then withdrawn. It dissolves the localized clot, blocking the line without significant systemic absorption. Very targeted.
So, looking across all these applications, especially the DVT and limb ischemia ones, we see this clear, overarching therapeutic trend emerging, don't we? Catheter-directed delivery seems to be the key innovation, trying to bridge that dangerous gap between efficacy and bleeding risk.
It really represents an evolution in the treatment strategy. By using catheter-directed delivery in conditions like severe DVT and acute limb ischemia, clinicians can often use significantly smaller total doses of the drug delivered locally, right where the problem is. This helps achieve the desired therapeutic result, dissolving the dangerous clot, while potentially mitigating that massive systemic bleeding risk, which has always been the Achilles heel of traditional systemic IV fibrinolysis. It allows doctors to harness the power of these drugs more safely in situations where the full systemic blast might just be too dangerous.
So, when we step back and put all these pieces together, what's the big picture? The journey of fibrinolytic therapy, starting way back with streptokinase in 1933, right up to the modern engineering of drugs like tenecteplase. It really is a profound story, isn't it? A constant balancing act. Balancing this unparalleled clot-busting power against the inherent, ever-present, sometimes catastrophic risk of severe bleeding. I think the key takeaway for you, the listener, from this deep dive is understanding that the timing, that 4.5-hour stroke window, the 120-minute PCI cutoff for stemming, the specific indication, whether it's a heart attack or blocked line, and crucially, the method of delivery, systemic IV versus targeted catheter, directed these factors, are absolutely as important as the specific drug choice itself in determining a successful life-saving outcome. It's a field truly defined by calculated, incredibly meticulous risk management.
And this really raises a fascinating forward-looking question, doesn't it? Given the incredible precision that's already required and the continuous refinement we're seeing, like as we mentioned, the ongoing clinical trials exploring connected place, potentially replacing alteplase in even more acute scenarios due to ease of use, how much closer are we really to achieving that ultimate medical goal, the holy grail, if you will, a treatment that gives us maximum clot breakdown power with minimal or ideally zero risk of catastrophic hemorrhage? Can we truly separate that powerful dissolving mechanism from the systemic bleeding risk? That, I think, is the next frontier in this research.
Thank you for watching The Funnel Effect.